For those of you not familiar with me, my name is Rob Valencius. I'm the National Agent Trainer here at Pinnacle Financial Services. I hope you guys are, having fun on this very odd Thursday in Pennsylvania. I think I've seen the sun probably 7 times today, and it always comes back to clouds and rain. So I'm not sure what it's like everywhere else, but it is an interesting day here. So today we're going to be talking about Medicare, kind of the ABCs, if you will, just a very top-down overview of the Medicare program. And I'm not going to go into a ton of detail about some of this stuff. We'll touch on hot-button things. I'll probably add in some things just based on experience. I'm an agent myself. I'm certified, contracted, and ready to sell. I use all the tools here at Pinnacle. So I'll try to throw in just some life experience into here as well. A couple housekeeping notes. Keep in mind, everybody is in listen-only mode. If you have any questions at all, there is a chat box. So do not hesitate to ask me a question. I will try to get to it as I go, and also at the end. I know time is important. You guys are not a salaried employee like I am, so I'll try to keep you out of here in under an hour. This is all being recorded, so if you get a call or you miss a part, or look, I'm from the Northeast. If I'm talking too fast, you'll be able to rewatch this at your own speed. And certainly, if you have any questions, I'll make sure that you know where to go to get my information. So with that being said, let's jump into this. Now, I always start any webinar I do here showing off our website, which is pffsinsurance.com. And one of the most important things to me is availability. You will run into a lot of FMOs and brokerages that will hide behind a email address, behind a 1-800 number. They'll have a ton of secretaries, or what we like to say in the sales world, gatekeepers, where you can't get through to somebody. We do not operate like that here. So if you go on our website under our About tab, contact our team, you will see that there is a picture, there is social medias, there is extensions and emails for every employee that we have in our home office here. We are based right outside of Philadelphia, Pennsylvania, in a kind of a small suburb known as Warminster, PA. And this is everybody here in the office. We kind of do things a little differently. Now, to put a little perspective on our company, we are a large FMO, NMA, whatever you'd like to call us. We've been around since about 2000, 2001, but our principal, Kevin Shields Sr., and our part owner, Angela Palo, have been doing this for a very, very long time. Kevin was a door knocker in the 80s for long-term care products. He worked his way all the way up and was very high up in long-term care companies known as American Travelers and Conseco, if you're familiar with them. He decided to do his own thing, so he actually left and bought this division and then made it his own. And that's when Pinnacle was established. And then it's about 2005 when Medicare Advantage first came out and then first launched as a program, or Part C. And we've never looked back. That's probably about 60 to 70% of our business yearly. We do tens of thousands of apps all across the country in every state. So that's a little background about us. We do things a little differently here. Our health sales team, if you want to take a look at this here, recently we've had some things move around, so this is a little bit of a fluid thing at the moment. Jeff Palo, he's the vice president of our entire health sales team. He was recently promoted. He's been with us for about 13 or 14 years now. James Norton actually recently left us. He went into the military, and I believe he's going down to Kentucky or North Carolina, and he's going to be fighting for our country. So hats off to him. We'll miss him here. Marcus is the lone guy left in this area, but We have some people we recently brought into the fold, and they're going to be kind of jumping in here. So in the meantime, he's going to be kind of spearheading these different states. So you'll see some new faces kind of float around as we kind of rectify and get everything coordinated here. Now Cody, Dustin, and Nick are all within the same team. They're good to go. But Nick was recently promoted to assistant vice president, so he is still within the team territory there, which all the states are listed. Our life sales encompasses life, annuity, long-term care. They're by product line, not by state. So if you've been doing business with us, you may have talked with Mark and Warren in the office. They handle the life and final expense. Will here is a senior sales director. He's been in the industry for a very long time. He handles a little bit more of the complex life annuity and long-term care products. And Josh, who's been with us for probably 7 or 8 years now, he was recently promoted to assistant vice president of all of the life annuity area, but he still also handles some more of the complex products and still helps agents. So that's just a little background on the sales team. I think it's always important to take a look at kind of everyone that works here, as well as who you're going to be, kind of. I was going to say face to face with, but unfortunately that's not a thing these days. So, but these are going to be the people that you're going to do work with, and you'll always have kind of a direct contact, but it's always good to have teams of people so that you always have someone to talk to, because we understand time is money. You're going to sit down with people. And if you need an answer right away, we want to be able to get that to you. So it's just something I always like to point out, when I'm going through these things. Just kind of keep that in mind. All right. On to Medicare. So this is a Pinnacle's quick guide to understanding Medicare. If you're new to the Medicare world, sometimes even if you've been doing this for a little while, there's some unique things. There's some I don't my 6-year anniversary with Pinnacle was yesterday, and my background was sales. It was not insurance in any avenue. And I know that when I first started learning, I was pretty overwhelmed because there's a lot of different things. There's a lot of acronyms, IEP, OEP, SEP, AEP. ICEP. I mean, you name it, there is probably an acronym for it in the Medicare world. So there's many different plans, right? There's if you're talking about Medicare Advantage, there's Part C, there's A, there's B, there's Part D, which is your drug plans, and then when you talk about supplements, there's A, F, G, N. I mean, there's letters for everything, right? So it can get very confusing, and it can get very cumbersome. We want you to know that we're a partner here. We're not your boss. We're not, we don't want to be known as your FMO. We want to be known as your partner. My job as a national trainer is to help you get through these objections and these hurdles and truly learn the material. So I'll go through this today. I'll put in my 2 cents. And if there's anything you're unsure about, and look, I get questions every day that sometimes I can't even answer for you, but I can get you answers. We have connections with all the major carriers, all the major reps, Nahu, you name it. If it's an oddball question, a rules question, we can always get answers for you. So I just wanted to make sure that was clear to you guys. So what is Medicare? So Medicare is a health benefits program for U.S. citizens or permanent residents who are 65 or older. Maybe they're under 65 but have certain disabilities, or any age but are diagnosed with end-stage renal or ALS, also known as Lou Gehrig's disease. New for this year, end-stage renal is covered. In the past, Medicare Advantage, that was the one knockout, was end-stage renal. But with some of the new rules and regulations, that is a thing of the past. So basically, you can get people coverage. It really doesn't matter what's going on. You can get them in something, which, you can't say that for every avenue of the insurance world. So, to me, out of all the insurances, I believe Medicare, not including drugs. I think drugs is still a hot button thing. I think the Medicare program has only gotten better. And I do believe that as we move forward, look, the pandemic changed a lot of things. Technology became a forefront. Thankfully, I got my IT degree about a year before the pandemic hit, so that's helped me here. But I think as we move forward, technology is really going to have a foothold within the industry. It is going to, and I was at United Healthcare's Medicare kind of first look program that they do every year. I've been at Aetna's, I've been to Humana's, I've been to Cigna's, and a lot of these companies, they're moving forward with different approaches. So in the past, the Medicare world, we would have a reactive approach. So the medicine and the kind of the therapy and the things that your clients would receive were reactive. They were based on them getting prescribed or them getting diagnosed, I should say, with cancer, with osteoporosis, with congestive heart failure, COPD. They would have to reactively take medication based on that, right? We are moving as a country and within the healthcare system, especially Medicare, as a proactive, right? So instead of reacting to the diagnosis, we're trying to be proactive to avoid the clients getting those diseases. And some things you can't help, right? Some things are hereditary, they're bound to happen. But some things you can avoid. Sometimes diabetes can be stopped in its tracks, right? Before someone goes into it. And a lot of these carriers, and you've seen it, they're having like, Apple Watches, Fitbits built into the program so that they can track steps. A staple of a lot of Medicare Advantage plans has been gym memberships. You're going to see even more of that. Aetna's doing some really unique things since CVS purchased Aetna, where they're having kind of like the all-in-one health clinics where they can go to a CVS, they can see their PCP, see their specialist, get their medicine, do everything, to do whatever they can to help the clients be as healthy as possible to avoid some of these really horrible diseases. And we've seen it. So, once again, not the materials, but just based on things I've seen and based on how long I've been in the industry and some of the events I've been to, it really looks like we're moving in a positive direction with the proactive approach and really trying to help our seniors live longer and healthier. So a little background, Medicare was signed into law in 1965. Your original Medicare, right? It's part of the Social Security Act that provides health insurance to the aged and disabled. It's administered by the Centers for Medicare and Medicaid Services, also known as our lovely CMS. They are kind of the government embodiment of Medicare. Right, here's all the parts we were talking about. You have your Part A, which is also known as the hospital insurance. Part B, which is known as the medical insurance, which is going to be like, your PCPs, your specialists. Part C, which is your Medicare Advantage plans, A, B, and sometimes D coverage all together. And then you have your Part D, which is your Medicare prescription drug coverage, right? Your PDP, as it's known. And then what's not on here is because it's not technically a part of Medicare, it's actually a supplement or a gap for Medicare, and those are Medicare supplements. So here's your Medicare choices, okay? Part 1, right? Part A, hospital insurance, and or Part B, which is your original Medicare. So A, and we're going to go into all this, right? Most people earn A free based on the quarters that you've worked in the country while you're living here. B is something you have to opt into. It does have a monthly premium, which we will get to. Now, with original Medicare, you can add a couple things. This is where your Medigap would come in, your Medicare supplement. You must have A and B. So with a supplement, it does not take the place of A and B. You actually are going to have technically 3 cards, because in most cases, if you have a supplement in original Medicare, you're going to also have Part D because you do need drug coverage. Drug coverage is pretty much required. Now, drug coverage does not require A and B. It just needs one or the other. So you don't have to have both for Part D. But, you do get penalized, and we'll go into all that. So when you do this option, you have your A and B card, you have your Medicare or Medigap supplement card, and then you have your drug benefit cards. You actually have 3 cards if you were to do the add-ons with original Medicare. Your other choice is original Medicare, but through a Medicare Advantage plan, which is also known as Part C. So what happens is, it's a MA or MAPD, Medicare Advantage prescription drug plan. The private company, and we'll just use, because I talked about them earlier, Aetna, right? We'll use Aetna as an example. Aetna would take over the assignment of Medicare for you from the government, while also potentially, in most cases, also offer a Part D. So you actually have one card that would encompass all of your Medicare, which is known as Part C, because they take over the A and B from the government while also offering you the D plan all on one card. Now, depending upon which Advantage plan you have, some cases you may be able to get a separate Part D, but 95% of the time you can't. Cost plans, which are not available in many areas, would be an example of you being able to add a separate drug plan. So let's go into a little bit of detail about what Part A helps to cover. So they help cover inpatient care, which is going to be your semi-private rooms, meals, general nursing, and drugs. It covers skilled nursing. So skilled nursing and kind of your rehabilitative services, which are typically provided on a continuous daily basis. After a qualifying 3-day hospital stay, so the cost on the skilled nursing would be nothing for the first 20 days. Then there's a co-insurance for days 21 through 100, and then the person after day 100 is responsible for all costs, which if you've ever had to deal with any of this, can get very pricey. And there's plans out there that we sell that can certainly help you with this. There's plans like hospital indemnity products, which we sell a tremendous amount of. Our agents do very well with it, that have skilled nursing riders attached to it, while also helping pay inpatient hospital stays. It's great products. If you haven't seen or heard about it, feel free to reach out to us, and we can talk to you a little bit about that. It also helps cover home health services, which are deemed medically necessary. This includes part-time skilled nursing, physical therapy, speech therapy, occupational therapy, hospice, which I know sometimes is a question on AHIPs and a lot of other things. This is covered by original Medicare. This is all items and services needed for pain relief and symptom management, medical, nursing, and social services, drugs, certain durable medical equipment, and aid/homemaker services. So here's some of the coverage benefit periods. Benefit period begins the day a beneficiary is admitted to a hospital or SNF, which is a skilled nursing facility. Benefit period ends when the insured has not received any hospital care or skilled care for 60 consecutive days. If the beneficiary goes into a hospital or SNF after one benefit period ends, a new benefit period will begin. The insured would not need to pay the hospital deductible for each benefit period. The beneficiary is going to pay the Part A deductible, which is $1,484 for 2021, for each benefit period. There's no limit to how many benefit periods an insured can have. So keep that in mind. There's no limit to that. So here's some of the numbers. In 2021, for each benefit period in a year, this is what they're responsible for. The deductible for Part A is $1,484. There's no co-insurance for days 1 through 60 of each benefit period. Okay, so any day between 61 and 90, the per day cost is $371. That's how much the client would have to pay. There's a $742 per lifetime reserve day, which is after day 90 of each benefit period. So all costs for each day after the 90-day reserve period, they're going to have to pay. Inpatient mental health care in a psychiatric hospital is limited to 190 days for a lifetime. So that's it. If they go over that, they're responsible for all costs. So for the SNF in 2021, the client would pay $0 for the first 20 days of each benefit period. For days 21 through 100, it's at $185.50, so obviously significantly less than the hospital. And then any day after 100, all costs they would be responsible for. For home health care, $0 for home health care services, and then they have to pay 20% of the Medicare approved amount for durable medical equipment. So here's just kind of I'll leave this up here for about 10 seconds. If you want to take a screenshot of this, this is just a nice little chart that organizes the expenses for Part A. So here's the cost for Part A in terms of premiums and all that. So as I mentioned, most people don't pay a premium. So if you paid federal insurance, if you paid the FICA taxes for at least 10 years, if you paid it less than 10 years, you could have to pay a premium. So what it equates to is 40 quarters. And we'll go into that a little bit, business quarters. Now, you may get a penalty if you don't enroll when you're first eligible. Your monthly premium could go up 10%. And you'll have to pay the higher premium for twice the number of years you could have had Part A but didn't sign up. So if you go 1 year, you could be paying for 2 years up to that extra 10%. And a lot of that stuff's decided by CMS. Now let's talk about Part B. This is the medical insurance. It's going to help cover services from doctors and other healthcare providers, outpatient, home health care, durable medical equipment, which can be oxygen, wheelchairs, walkers, hospital beds. And it also helps cover many types of preventative services, which we will talk about. So this is some of the different conditions, some of the things that they cover, alcohol misuse screening and counseling, ambulance. There's a limited eyeglass coverage, flu shots. There's a lot of this stuff that is, like depression screenings, chemotherapy. This stuff is really important in a lot of aspects for some people, especially things like flu shots where they need to get them every year and things like that. Some more physical therapy, laboratory services, dialysis, prostate cancer, different tests, you name it, it's on here. So here's a little talk about the premiums, coinsurance, and deductibles. So beneficiaries are going to pay a deductible each year. For 2021, it went up to $203. This past year, it was in the 190s. And it goes up typically, I want to say, anywhere from $5 to $10 every year that I've seen so far since I've been here. After you pay the deductible, 20% coinsurance on most of the Part B covered services will be required. Beneficiaries will have no cost sharing for most preventative services. So here is the Part B, kind of the little graph that we had just for Part A. So here's some things that aren't going to be covered by A and B. So that's one thing to note, right? Medicare does not cover everything. Here's some of the things that kind of are hot button things, a couple of them, right? Acupuncture, Most dental care, which includes dentures, eye exams relating to prescribing glasses. I mean, dental and eye and hearing, which is on here, that's probably one of the most talked about add-ons. And especially when we get to the Part C, that the carriers have really identified. Those things are not covered by original Medicare. Things like orthopedic shoes, routine foot care, LTC, and some of the vaccines, which does not include obviously COVID. That's been worked into basically every program, whether you're over 65 or under 65. So I've mentioned the term a couple times, but original Medicare, that's always going to be Parts A and B. And then, depending on what your specific client's case is, some of it could be signed up automatically. Some of it could be manual. So, a lot of times if they're, they're going on disability, as long as they've been on disability for 24 months, they'll automatically be enrolled into A and B, and they'll be assigned a Part D plan automatically, with no agent. So there's a lot to that, and we're not going to go into a lot of that today. So here's the reasons why you would be automatically signed up for Medicare. So you already got benefits from Social Security or the Railroad Retirement Board, which is also known as RRB. You'll automatically get A and B starting the first day of the month you turn 65. If your birthday is on the first day of the month, A and B will start the first day of the prior month. So you kind of luck out there if your birthday is the first of the month. If you're under 65 and disabled, as I had mentioned, if you're receiving the disability benefits from Social Security for 24 months, you'll automatically be enrolled. If you have ALS, also known as Lou Gehrig's disease, the month your Social Security disability benefits begin, you will automatically be enrolled. And then if the beneficiary is automatically enrolled, you'll receive the Medicare card in the mail 3 months before your 65th birthday or the 25th month of receiving disability payments. The beneficiary does not need to do anything to keep their B coverage and will have to begin paying their Part B premiums monthly. We'll talk about that as well. You'll need to sign up manually for these reasons. If you're close to 65 but you're not receiving Social Security or RRB benefits, which happens to a lot of people. You have ESRD and you want Medicare. You live in Puerto Rico and receive Social Security or RR benefits. You're going to need, if this is the case, you'll need to apply for Part B manually by completing a specific form that's on the Social Security website. So here are some of the things that we had talked about. IEP, SEP, right? General enrollment period. So IEP is initial enrollment period. SEP stands for special enrollment period. And then there's GEP, which is general enrollment period. Now, what do these mean? So your initial enrollment period for A and B is when you can first sign up for Part A and or B, which is during a 7-month period. This is going to begin 3 months before you turn 65, the month you turn 65, and 3 months after. So 3 months before, month of, 3 months after. If you sign up for A or B during the first 3 months of your IEP, in most cases, your coverage is going to start the first day of your birthday month. However, if your birthday is on the first of the month, it's going to start the first day of the prior month. Right? Month you turn 65. So here is an interesting tidbit. So if you are going to sign up after you turn 65, it's going to change when the coverage starts. So if you sign up the month you turn 65, your coverage starts the month after. If you do 1 month after you turn 65, it starts 2 months after you sign up. If you sign up 2 months or 3 months after you turn 65, it starts 3 months after you sign up. And if you sign up during the general enrollment period, which is January through March, your coverage will start July 1st. Those are for the people who don't sign up when they're supposed to typically. Or maybe there's a lapse where they decide to not pay their Part B premiums, or some of the more odd things is when you'd use the general enrollment period. So I'll leave that up if you want to take a screenshot. All right, let's continue on. So when do you sign up for A and B when it comes to a special enrollment period? Okay, so here's some of the reasons behind an SEP. If you or your spouse are still working, you may have a chance to sign up for Medicare during a special enrollment period. So for those of you that are still working, you're not required to activate Part B. And then when you leave, you activate Part B, you get a special enrollment period to sign up. So if you're covered under a group health plan based on your current employment or your spouse's, so if you're working and your significant other is on that policy, it would also kind of follow that as well. So when you're first eligible for Medicare, so if you're 65 and you're working, you don't want to sign up for Part B, you don't have to, and you will not be penalized. But then maybe you retire at 70, you would get an SEP to be able to sign up for Medicare. So anytime you're still covered by the group health plan, and then during the 8-month period that begins the month after your employment ends or the coverage ends, whichever happens first. So usually you're not going to pay a late enrollment penalty if you have an SEP. Like if you're working and then you go to retire, you're not going to have a late enrollment penalty because you had credible coverage during the period. And a lot of people do that because I don't know about you, but if I have group coverage, I'm not going to pay for my Part B premium if I don't have to. It's not like it's a Netflix subscription of $10 a month. You're talking like I believe it's $144 and some change, and we'll talk about that, but it's not cheap. So the general enrollment period is if you didn't sign up for A or B during your IEP and you don't qualify for a special enrollment period. It runs January 1st through March 31st, as I mentioned, but your coverage won't start until July 1st of that year. And you may need to pay higher A or B based on how long you weren't covered. We talked about the coverage there for A, but B, it's 10% for each full 12 months eligible that you could have enrolled in B, but you did not. They like those round numbers, 10%, 1%, somewhere around there. Makes it easy for them, I guess, to do the math. So how much does Medicare cost, right? How much does Part A, premium-free Part A, if you must pay for Part A? How much does Part B cost monthly? And what is the Part B annual deductible? So to get a premium-free Part A, right, usually you don't have to pay the monthly premium for Part A if you or your spouse, some people don't realize that. So if you were married, if you were married to your spouse that whole time, if you paid Medicare taxes, they paid Medicare taxes while working, premium-free Part A is what you'll get. So you can get free Part A if you already get retirement benefits from Social Security or the Railroad Retirement Board. You're eligible to get Social Security or Railroad benefits but have not filed for them yet. Or you and your spouse have Medicare-covered government employment. Sometimes that's tough with the people that have government employment, government pension style stuff, teachers. Sometimes it's a little difficult to kind of pinpoint because they have really, really good coverage. And if you're under 65, you can get the premium-free Part A if you have Social Security or RRB disability benefits for the 12 months, or you have end-stage renal and meet certain requirements. Now, you can still get Part A if you don't qualify, but you're going to need to pay a premium for it. So if you paid Medicare taxes for less than 30 quarters, the standard Part A premium is $471 each month for 2021. But however, if you've worked and paid taxes for 30 to 39 quarters, the standard Part A premium is $259. So it drops significantly if you at least worked 30 to 39 quarters. In most cases, if you do choose to buy Part A, you're also going to have Part B, and you're going to have to pay monthly premiums for both, which can get a little costly. So how much does Part B cost? It did go up for 2021. The standard cost is $148.50. However, based on your income, this could be double. So it really depends on the client and how much, as a married couple, they're bringing in. So you'll pay the standard Part B premium if you enroll in Part B for the first time for 2021. You don't receive Social Security. You're directly billed for your Part B premiums. You have Medicare and Medicaid, and Medicaid pays your premiums. So your state will actually pay the standard premium, which would be $148.50. Or your modified adjusted gross income, as reported on your IRS tax return from 2 years ago, is above a certain amount. If that's the case, you'll pay the standard premium amount and what they like to call IRMA. You've probably run across this, which stands for Income Related Monthly Adjustment Amount. It's going to be added to the premium. And that's where we're talking about it could be higher based on that IRMA. So a lot of people always ask, well, what's IRMA? I just explained it. And what are those income adjustments? Here you go. This is a nice, handy form for you to take a look at. I'm going to give you 10 seconds. Take your screenshots or write down the information. This is definitely something good to have because I know I've had some clients, unfortunately, that have had to pay some IRMAs on their monthly Part B premium. All right, let's move on. So what's the annual deductible? So for 2021, Part B's deductible amount is $203. Okay, this must be paid prior to Medicare beginning to pay for their portion of the Part B covered expenses. Keep that in mind. All right, so now we're getting into the nitty gritty, right? This is probably one of the best way to put it is lucrative avenues in the Medicare world. And honestly, I think these plans have only become more and more enriched over the past 3 to 4 years. So, let's talk a little bit about what Medicare Part C or MAPDs are. So they include all benefits and services covered under A and B, and these usually include a Part D as part of the plan. It's run by Medicare-approved private insurance companies that follow rules set by Medicare. So Medicare states these plans need to meet these certain criteria. So all of those plans have that, but all the co-insurances, co-payments, those things could be totally different. And the great things about these plans is all of them, or many, at this point have many rich benefits added. Things like dental, vision, hearing, wellness programs. We've seen some really creative ways. You're going to see over-the-counter debit cards. You're going to see transportation built into regular plans. I've even seen some smaller plans have pet boarding. In case your client has to go spend 2 days into the hospital, they'll pay for their pet to be boarded. So there's some very unique things, and you're going to see more and more rich extra benefits added to the plans, I think, as we keep going. So let's talk a little bit about the different types. And some of these you might be familiar with, right? HMO, PPO. Some of these aren't as prevalent in today's market, but let's go over this. So the first one we'll talk about is what's an HMO. HMO stands for Health Maintenance Organization. So generally, the insured must get care and services from doctors within the HMO's network. Most times these HMOs do offer prescription drug coverage. You will need to select a primary care physician, and in almost, I would say not all, but in a huge chunk of these, you're going to need referrals. Your doctor needs to be contracted with the plan for you to be able to see them. If they're not, you will not get coverage through your plan to see that doctor, meaning you will have to pay the full value to see that doctor specifically. Referrals, if you're unfamiliar with them, that's where your primary care physician would have to write to wherever you need to go, specialist-wise. Maybe you need to see a chiropractor, whatever the case is. They would have to specifically refer you to them in order for you to be able to go see them. PPO. This stands for Preferred Provider Organization. We've seen more and more PPO options pop up. In the past, PPOs have, especially, there's different kinds of PPOs. You might just see a standard, but there's also LPPOs and RPPOs. So L stands for local, R stands for regional. Regional typically are, the most expansive in terms of the PPOs. So you might have a regional PPO cover an entire state, or I even see United Healthcare, I know, has some that covers like Georgia and South Carolina, so two full states. And it just gives some flexibility on out-of-network costs, right? So PPOs have network doctors and other healthcare providers, but you're also able to use out-of-network providers for covered services, but typically you're going to pay higher costs. Most cases, drugs are covered, or at least drug coverage is offered. You do not need to set a primary care physician, although they still like you to do that, but it's not required. Most cases, referrals are not required within these plans. And PPOs have built-in extra benefits, but in a lot of cases, HMOs tend to have the most extra benefits built in compared to PPOs. So, as you'll go through these, you'll see there's there's positives and negatives, right? HMO, the negative, you have to see contracted doctors. If the doctor you've been seeing for 20 years isn't contracted, well, you either see him and pay full price, or you have to change your doctor. But you might get free transportation to and from that doctor. And on top of that, you might get $2,000, $3,000, $4,000 in yearly dental coverage, which is huge, right? But if you have a PPO, you don't have to worry about really seeing anybody, because no matter what, you're at least going to have some form of coverage. But maybe instead of $4,000 in dental, you get $1,000. It might be a quarter of what that HMO would have had. So, just some things to kind of keep in mind. So PFFS plans, not to be confused with PFS, Pinnacle Financial Services, they're private fee for service. Under a PFFS plan, you can go to any Medicare-approved doctor, other healthcare provider, or hospital that accepts the plan's payment terms and agrees to treat you. It is important to note they're not required to agree. So if you have a PFFS plan, the doctor has to agree, and if they don't agree, then you can't use their services. That's the important thing to note, is that they're not required. They have to agree on their own to treat you. So if the PFF has a network, you're always going to be able to go to them for the covered services. The PFFS plan does not offer drug coverage. This is one of the options that will allow you to join a Part D separately. You do not have to choose a PCP here. You will not need a referral, and the plan decides how much you pay for services. SNP plans, or special needs plans, these are for a particular subset of the population. Okay. Generally, these are going to have a network, so you're still going to have to see people within the plan's network. Every SNP plan that's out there is required to have a Part D built in. So you're never going to see a SNP plan that does not have Part D built in. PCPs are going to be required to be selected for these, because obviously the care model for these plans is going to be heavy. You're dealing with people that, and you're going to look at the subset of groups here, but you're going to be dealing with, nursing homes. You're going to be people that have Medicare and Medicaid, also known as dual eligibles or D-SNPs. You're going to be dealing with people that have chronic or disabling conditions. Some of the more common ones like, congestive heart failure, diabetes, HIV, that type of thing. You're going to run into that. And these plans are going to they're built specifically for that specific disease. So when do you join, switch, or drop a Medicare Advantage plan? Some of you might be familiar with some of these, right? So when you first become eligible, you can sign up during your IEP. If you have Part A and you get Part B for the first time, you can also join a Medicare Advantage plan. So that's during the GEP or General Enrollment period. Every year, there is the annual election period. This runs October 15th to December 7th. Now, you can talk about the new plans starting October 1st through the 15th, but you cannot sign anyone up during that time. So if you sign someone up during the annual election period, the coverage begins January 1st of that next year. You know what? This was not adjusted. So disregard the bottom of this. I don't know why this we didn't adjust this, but this used to be the old disenrollment rule. It is actually now known as OEP or open enrollment period. So from January 1st to March 31st, this is for anyone with an MA plan. They can actually switch and go to a different MA plan. It's a one-time switch. And they started doing this because a lot of people started to enroll themselves online. Or maybe they got a captive agent that only sold one product. And it was turning out that a lot of these people weren't getting the appropriate plan based on their treatment needs. So there is a 3-month enrollment period that gives you the opportunity to put them in the appropriate plan. Sometimes people don't put in all their drugs that they need to, or their doctor, maybe their main doctor, they don't want to change and it's not covered in the HMO's network. So just kind of keep that in mind. So what is Part D? Part D helps cover the cost of prescription drugs. It is run by Medicare, approved private insurance companies, so it kind of falls under the same umbrella as Medicare Advantage. And it may help lower the prescription drug costs and help protect against higher costs in the future. Now, are the drug plans perfect? No. It will save your clients typically a decent amount of money. Where it gets fuzzy is when you get into the higher end medications that are injectables and special medications. And unfortunately, if you're in the Medicare program, it is a federal program, not state run. A lot of these seniors are not able to apply and get a discount card. Like I take Tremfya, it's for psoriasis. It's a tier 5 drug. If I did not have insurance, my drug would cost $12,000 every 2 months. But because I have commercial insurance, I'm eligible, and I'm not on a federal program, I'm eligible to pay $5 a prescription. That is a huge difference. Unfortunately for Medicare, if you're on a federal program, you cannot qualify most times. So our seniors get hit with some pretty big expenses once they start to hit the injectable and special programs that are typically within the higher tiers in the drug program system. So Medicare Part D covers prescription drugs with everyone, basically with Medicare. If you decide not to join a drug plan when you're first eligible, you are likely to pay a late enrollment penalty if you join later. So the two ways to get coverage is through a standalone drug plan, which you can get with both original Medicare and a Medigap, or through one of the many Medicare Advantage plans. The drug plans follow the same exact rules as Medicare Advantage, so I'm not going to go through them again, but it literally follows the same exact rules. So let's talk about the costs. With Medicare Part D, there is a yearly deductible. I believe it's the max for 2021 was $445. I've seen that go up every year, so I'm sure for 2022 that amount will change. That is the maximum amount that the plans are allowed to put as deductibles on their plans, set by CMS. Some of the more expensive plans, there's not many, but some of the more expensive plans either don't have a deductible or they're not expensive. Maybe they're $95, $150, but they're not $445. So this is the amount that you're going to need to pay before the drug plan kicks in. And then there's co-payments or co-insurances, which, is a, kind of a shared responsibility between the plan and the client. Now, let me explain this a little bit. You're going to hear a lot of different things called the gap, also kind of known as the donut hole, catastrophics on the next slide. So there is 5 tiers typically for a drug plan. Tier 1 being the preferred generic, Tier 5 being the specialty drugs. Some plans have higher, Tier 6, but that's the standard. There is 4 phases. Okay, so there's the deductible phase, which is phase 1. There is the initial coverage phase. Okay, that's phase 2. Then there's the gap, which is the donut hole, which we're about to talk about. And then there's catastrophic. A lot of these drug plans and MA plans with drug coverage built in will ignore phase 1, which is the deductible, and go right into the initial coverage phase. If it's a generic drug, lisinopril, atorvastatin, some of those kind of preventative and blood pressure related medications. But if it's a higher end one, some tier 2, tier 3, tier 4 and up, you're going to have to pay the deductible right away. So I wanted to kind of explain that because I think that does help. So the coverage gap has changed a little bit. It begins after you or your drug plan together has spent a certain amount on covered drugs. In 2017, once you entered the coverage gap, you pay 40% of the plan's cost for covered brands and 51% of the plans for generic. And that has actually changed. It's not that way anymore. They've adjusted that. I believe it's 20%, and it's a little bit easier. But the coverage gap is where your client spends the most amount of money on their drugs. So these costs, which are actually sometimes called true out-of-pocket or TROOP, they all count towards getting you out of the coverage gap. So the deductible, co-insurance, co-payments, even the discount that you get on covered brand name drugs, and then what you pay when you're in the coverage gap help you get out. The one thing that you need to worry about, though, is that the premium and what you pay for the drugs that aren't covered don't count toward getting you out of the donut hole. Catastrophic coverage, once you get out of gap, you're only going to pay a co-insurance or co-payment for the covered drugs for the rest of the year. So catastrophic is where you typically will, outside of the initial coverage phase, catastrophic is where you pay the least. So, the plan cost, all the drug plans have a premium. If you have higher income, you might get an IRMA. You might have to pay more. There's set amounts there. I'm not going to go through all the different amounts, but there is IRMA with Part D. Extra help or low income subsidy will help pay for premiums and drug costs. Now, we had talked about this a little bit. You will get a late enrollment penalty if you fail to enroll in Part D when you're initially eligible to do so, or if you have 63 days or more after not choosing a plan. Okay, the way this works is you will get, and you can calculate this if on your own if you like, 1% of the national base premium. Unfortunately, this is off a little bit. I think it's $33.05 for 2021. So I apologize for that. So don't take that number specifically, but 1% of $33.05 for 2021 and you times that by the full uncovered months that you were eligible but did not choose a drug plan. So that can get very costly for someone that's been out of the drug plan for, maybe they didn't choose a plan for 10 years. And believe me, at this point, we've seen just about anything. All drug plans, I like to call these the Bible of drugs for the plan itself, right? They're called a formulary. The formulary is all the drugs that the plan covers, and they're broken into those different tiers that I talked about. Each tier is going to have different costs, so tiers 1 through 5. Tiers on the lower are going to have a lower cost than tiers on the higher, which, tier 4, 5, whatever the case is. So there's many different rules. There might be what they call prior authorization, okay? And you have to get, authorization by the plan to take those medications. So your doctor basically has to say, hey, my client needs this medication. I need you to prove it so I can prescribe it. There's also quantity limits. You're going to see a lot of that on opioids. They've really cracked down on that. So they might say, okay, we'll give you Percocet, but only 30 per month. Anything more than that, not covered. And then, some things might require step therapy where they want you to try other lower cost drugs before they prescribe you the drug that the doctor wants to put you on. Like I said, I take Tremfya. It's a very expensive medication. They've tried to have me do light therapy and some other stuff, topicals, things like that before they moved into that. And sometimes you can move past step therapy if you have a good doctor. So real quick, Medicaid. We're not going to go into a ton of this, but it's always good to know what it is. Medicaid is a joint federal and state program. It's going to help pay medical costs if you have limited income and resources. People who qualify for both Medicare and Medicaid are what is known as a dual eligible, which I had mentioned earlier. A dual special needs plan designed for dual eligibles, people who are 100% Medicare and Medicaid. Now, to qualify for Medicaid, you're going to need to meet the minimum income and resource requirements that are, these differ by state. Okay, people with Medicaid are going to get coverages for services that Medicare may not cover, or only covers partially, stuff like nursing home, personal care, community-based services. And that's it. I wanted to mention the Medicaid at the end. We weren't going to go into a ton of detail, but it's always good to jump into that. So, like I said, I apologize for the couple things we missed there. From an amounts perspective, but hopefully, I didn't really want to get into those numbers and those amounts because sometimes they get a little confusing. Hopefully, you have a better understanding of the Medicare system as a whole. Now, if you have any questions, you need any one-on-ones, feel free to reach out to me. All my information is available on the website. I'm an agent myself. I've gone through a million different scenarios. I was in sales here for 5 years before I moved into the agent training role. So do not hesitate to reach out to me. I don't see any questions, so I know we went a little over what I wanted to hit. If anyone has any questions, don't hesitate. I'm always available. And I always like to end these with thanking you guys for taking the time out of your day to hang out and talk Medicare with me. So have a great day, guys. We're one day closer to Friday. So have a great day and a good hump day, middle of the week. And I look forward to talking to you guys again on the next webinar. Thank you.